All right. All right, everybody. Let's start with the next session of Virtual Spine as a continuation of last week's robotics session. Today, we are very honored to have Dr. Jeremy Steinberger. He's an assistant professor of neurosurgery at the Mount Sinai Health System in New York City. Dr. Steinberger recently joined the faculty over there, and his specialties are minimally invasive surgery and augmented reality. With that being said, Jeremy, we are all very interested in hearing your talk.
Thank you so much. I will share my screen. Am I shared here?
Yes, but you're under presenter mode, Jeremy.
Hold on, let me just quickly switch out of that. Hold on. How about now?
Looks good.
All right. Good evening, everybody, and thanks for joining me at this late hour. I want to start by thanking the Virtual Spine panelists because I have been watching and loving the lectures over the last few weeks and months, and you've done an outstanding job of putting together great speakers and great topics. So it's been great. I'm sure this is going to outlast COVID by a very long time. I think that you've hit on something great. So thanks for having me as a panelist. Honored to be here. And with that, I'll talk about augmented reality and spine surgery, which is just a very exciting topic, mainly because we're at the very infancy of what applications are going to happen in the next few years. And I think that the most exciting thing is the future more than the present, but certainly the present is very exciting also. And that's what I'm going to talk about today. Good. Okay. I am a consultant for Stryker ZB, and neither will be relevant in this talk. I want to start by showing some trends. If you look at augmented reality and spine surgery on PubMed, you were at a very nice increase from 2019 to 2020. The robots are starting to plateau. So I think, you see where the excitement is. And I say that in jest, but the truth is that ultimately, of course, robotics and AR are both coming to spine. They're both hot topics, but I think that robotics are a little further along than augmented reality as far as like being applicable in the OR today. And I think that's what makes AR so exciting to me because there's some new exciting features coming out soon. I want to start by painting a picture of where I think AR is going. And then of course, time will tell. But I think number one, right now, there's a lot of steps in a lot of these different companies' augmented reality headsets. And ultimately, the first thing we're going to get better at is efficiency. And it's not going to take time. It's just going to be a seamless integration of AR and the OR. So I imagine you walk into the OR with your headset on. You don't need loops because you have a magnifying glass on your headset. You don't need a headlight because you have a light on your headset. There's going to be a way shortly where you don't have to register the patient. You cut out that hassle that takes 10 to 30 minutes. Once you're registered, you won't need fluoro because you have see-through vision and you can see the spine through the skin and look at landmarks such as the PSIS or whatever. You don't need to put up DICOM on the wall or print pictures into the OR or have it up on the computer screen. You can have the DICOM images with easy scrolling, either voice controlled or with just a manual, stick your hand out and pinch or scroll. So you have DICOM at your fingertips. And then ultimately, it's not just going to be a screw insertion technique. It's going to be useful for the laminectomy portion of the surgery, the instrumentation part of the surgery, and for the interbody part of the surgery. And of course, if it's a tumor or if it's an AVM or whatever, it's going to be useful for all aspects of the operation that you're intending to do. So I think that to me is where I see things going. And then is this 2025? Is this 2030? I would argue that it's going to be a lot sooner than that. And I think, we're looking in the next 1 to 3 years. I think this is going to be the picture that I envision. And then you fast forward 10 years, and I think we can expand these applications even further. So I think we can start seeing patients in the comfort of their own home. I think this is, of course, coming to mind because of COVID and how everyone likes to do their televisits. But I think ultimately, it's really nice to have a preoperative counseling session where the patient can stay home and you can review their imaging. You could show them the video of their pathology with the surgery planned and how it's going to look at the end. In a seamless PACS to VR, AR model. It's not going to take 20 minutes to build this model. It's going to be seamless. There's going to be protocols in place that just go from PACS to model, and it's going to be accurate and it's going to be helpful. And I think, of course, these are all different realms, but we have, Air OCT and OARM and Zeem for navigation. We have the Globus and the Mazor robot and others coming soon. We have augmented reality and Augmetics and others. I think they're all going to integrate together, and it's going to be, all these technologies are separate, but they will be combined. And then ultimately, in 10 years, I do think we could be remotely operating these technologies, potentially from a different room, or who knows. And the last thing is, and this may be debatable, and I think but I think that and I'll show some pictures, but when you can train med students and residents with a VR model and they can practice putting in screws before the case on this patient's pathology and look at it and and then, get a medial breach on their pedicle screw, but then see that they did that and find ways to not do that in the real case. This is a risk-free environment that you can practice in. I was practicing drilling a laminectomy trough in the cervical spine with a medical student. And if I had done that as a medical student, I just feel like I'd be much more ahead of my time and much more comfortable doing things that maybe I wouldn't be comfortable with otherwise. So I do think that, residents have their 80-hour work weeks and increased restrictions on in that realm. And I think that if they have this ability to gain better skills on a virtual model tailor-made to a specific patient, they can have enhanced operative maturity and be able to accomplish their tasks in a more comfortable way and in a more skilled way. So that's where I think another potentially very advantageous part of virtual and augmented reality is. So in spinal VR and AR, I want to talk about where we are and, of course, where we're going. And there's a lot of different ways that we are applying this. So there's benefit to the patient, of course, in consultations and understanding and comprehension and consent and informed consent specifically. There's definitely a role with training residents, training medical students, training advanced practice providers, and then the intraoperative applications, which of course are the most fun and the most exciting part of it all. Of course, I have to quickly start by talking about the definition. So briefly, virtual reality, as most of you probably know by now, you put a headset on and you're transported into the world of whatever you're looking at. You're not involved in what you're seeing in the real world. It's a computer-generated simulation of a 3D image. This is particularly helpful in the education realm, in the patient education and the resident education, and preparation for cases in advance. So it's just a way to look at build a model, look at it and study it and understand potential pitfalls of what you'll see in the OR. And again, this is a controlled setting. So if you're doing a tumor resection, which I'll show a picture of, that's involving the vertebral artery, you can learn from your mistakes in a risk-free environment. If you drill a little lateral on your model and you hit the vert, well, you didn't do that in real life. So you'll know not to do it in real life when you start the case. So I think that it's advantageous from medical student to intern to resident to fellow to attending. And interestingly enough, when we rolled this out at Sinai, I was surprised to see that attendings were taking equal or above an interest of the trainees, because I think, to look at an aneurysm, for example, because we're using this in cranial applications also, to look at an aneurysm beforehand and really understanding that the angle you're going to approach with the clip, it's just as an attending, you're very in tune with the subtleties of what to look for in advance and what angles you're going to have and everything. Augmented reality is a merging of the virtual world with the physical world. So you're looking at a patient or you're looking at the room around you, but superimposed on your view, you have the patient's relevant anatomy. So you're looking at a patient on the OR table, you're either exposed or not exposed, but you're seeing their spine and you can manipulate their spine in certain ways, which I'll show. So the user has a wearable item with a display of relevant anatomy projected onto the physical view of their world. And as opposed to virtual reality, which is good for training, good for education, augmented reality is going to enhance the way we do procedures in an intraoperative environment. And one of the big appeals of augmented reality is when you're doing a case, we've all gotten comfortable using navigation now. So if you're putting a pedicle screw in, a lot of us are, let's say it's a very rotated pedicle in a complex deformity case, you're not even potentially looking at the patient, you're lining it up on the patient, you're turning your head away, you're looking at the computer screen, you're looking at the navigation to get the perfect pedicle screw. But ultimately, at least when I do that, I have the resident or whoever's on the other side looking at the patient and making sure that, you're not drifting at all. And ultimately, if you can eliminate that aspect of diverted attention and looking away from the patient while you're operating on them, that's a good thing. And then ultimately, we can do this now if you have the superimposed navigation view onto your augmented reality headset. So there's no diverted attention. And I think that's really a huge advantage to augmented reality. Additionally, when you're taking out a tumor that's, let's say, intermittently opposed to the spinal cord or it's intramedullary, if you combine on your microscope view, you can absolutely paint relevant structures. If it's a cervical tumor, the vertebral artery, if it's a thoracic tumor, Adamkowitz or whatever. So I think that that's another advantage to augmented reality. These are articles from Sweden and Switzerland, and I think the third one's from London. And ultimately, this is an exciting thing all over the world. It's all over the news in the US. And I think despite all the interest, we are in the infancy of application of augmented reality, and the practical OR applications in spine surgery today are minimal. I think this has changed even over the past few months. And it's, a good friend of mine who was a co-panelist with me a few months ago, Hassan Jazini, where we talked about robotics and virtual and augmented reality. He's using laminectomies with augmented reality. I think he's the first one to do so. So I think every day, if you're keeping track, there's new developments and new exciting adaptation to augmented reality in the OR. Ultimately, the first FDA cleared device was the Augmetics X Vision for augmented reality. Here's a picture of how it works. And the first time I tried this on, it was extremely wowing to me. You feel like you have see-through vision. You're looking at the spine through the skin. It's scary at first because you're relying on this technology, but ultimately you're relying on navigation in the same way, where you're trusting the computer, and ultimately using it over and over again is what gives you the confidence that it's trustworthy. In addition to you checking intraoperatively, the way I like to do it with a augmented reality pedicle screw is to sweep along on the transverse process, the top, the bottom, the medial, the lateral edge. And when you feel those step-offs, that gives you confidence that it's accurate, and then you can proceed with the screw.
Hey, Jeremy?
Yes.
Hey, it's Ali Bash. Sorry to interrupt, but I have to ask you a question right off the bat before you go on. First of all, thank you for joining us again. You're one of the very few guests who has come back to give us another talk. So we're obviously very excited about that, and what you're doing is really important. Got a question here, and I'm going to put you on the spot. If somebody came to you, if your hospital came to you and said, "Hey, we're going to give you the resources, but you can only choose one, either an AR system or a robotic system. You can only choose one. Which one would you choose?"
AR. For a few reasons. Number one, it's like I'm very passionate about it. I've loved it for many years, and I want to like propel it forward because I do see so many applications for it in the future. Also, I think, failure is success in progress. I think Einstein said that. So I think, to me, not that the robot is a failure. Robots are amazing, and I don't have one yet. And I do want one, by the way. I want both. But I think the robot
No. You can't have both. That's, I mean, obviously I'm joking.
My answer is AR. My answer is AR. But I think that the robot, where it stands today in January 2021, I don't think it's adding much to navigation. I think that, and personally, I like having the tactile feel, and I like to be holding the instrument without being pigeonholed through the tube with the robotic arm. That's just me. And I have a lot of respect for people who are working to get the robot better. But I think that the robot in 5 years and 10 years, similarly to AR, it's going to be vastly different. And I think both are going to be instrumental to spine surgery. But ultimately, I see AR as the one-stop shop. You put it on, and it does everything for you. But you're using your own hands to do that. And I still like the aspect of me holding the instruments.
Got it. Thank you so much.
Absolutely. It's a great question. So this was the first VR case that we did at Mount Sinai. It was a 72-year-old who ended up having, as Wendy Gibbs predicted, a lymphoma. on our Twitter discussion, but is a patient who came into the hospital with left upper extremity weakness and this C3 bony lesion and an epidural component, as you see here on the T1 sagittal contrast images. And it's kind of circumferential to the cord. And we were consulted, we were working the patient up for an IR guided biopsy, but he got acutely weaker and we ended up taking him to the OR. And you read this patient, the riot act before surgery about every possible risk from death, coma, paralysis, weakness, sensory, et cetera, et cetera, et cetera. But ultimately, you tell that to a patient who's never heard of spine surgery in their life, it goes in one ear and out the other. And that patient, even if they're very smart and very in tune, it's very hard to understand when a surgeon's spitting forward all this information. But I think that when you show them this video, they have a much deeper understanding of what you're doing, what it looks like, where is their spinal cord compressed. And it's just so many patients have this moment where it just clicks for them and they understand, this is where the vertebral artery is, this is where the spinal cord is, this is really interposed with my spinal cord extremely closely, and I understand why things can go wrong. I think this is one of my favorite advertisements from Regenex, which is, I think, a stem cell injection kind of, but back fusion surgery. Sorry, you're still in pain, but the x-ray looks great, which is, I think that's been said. And I think that the whole mentality in 2020, 2021 is shifting, that it's really not about the x-ray, it's about the patient. And I think, to me, this is a huge part of walking them through the procedure, having them understand it, and it makes a big difference. And recently we started adopting ERAS, Enhanced Recovery After Surgery model, and we're doing a lot of work on propelling this forward. But for those of you who don't know, it's a comprehensive perioperative care model to optimize outcomes with a faster return to baseline. It's been shown to work from total joint arthroplasty and then colorectal, cystectomies, pelvic surgeries, pancreatic. Every surgical subspecialty is adopting these techniques. I think ERAS might be patented, but the themes of ERAS and the principles, adopting them into their practice. So what is ERAS principles? A focus on the patient and the patient experience, a multidisciplinary team approach, efforts to reduce pain, morbidity, and recovery time, and a data-driven iterative improvement process. And I think here's some list of practical things that we do in the pre-op, intra-op, and post-op periods. But among them is the patient counseling. And when a patient's informed, I think every step of the way, they're more inclined. For example, when you walk a patient through, if you're patient with them and you explain to them that if you don't stop smoking, your risk of infection is much higher. Your risk of osteoarthrosis is much higher. Why is it so important to get out of bed the day after surgery? All these things I think are critical in the global view of the patient. But I want to focus on the counseling aspect, because when a patient understands what you're doing, what's expected of them, they do better. Their outcome is better after surgery. And I think that ties into this whole talk, really. This patient underwent a posterior cervical decompression, a tumor biopsy, and a partial resection. Once we got the frozen showing it was lymphoma, we actually stopped. As of last month, the patient is cancer-free and doing great. This is a 39-year-old male, and I just love this case. I think I may have shown this last time, but it's such a great case to demonstrate the same themes. So this guy came to the emergency room in January of 2020. So really, right before the COVID pandemic was heating up, and he was weak in all four extremities. He had gait imbalance, frequent falls, paresthesias, and urinary incontinence for a day, which brought him to the ER. He had this massive C6-7 disc herniation. And you talk to the patient about what we're going to do, and I think you talk to the intern or resident, you talk to the medical student, and you talk about the esophageal retraction and dysphagia postoperatively, the carotid artery, jugular vein, vertebral artery, spinal cord, the indentation of the spinal cord with the herniated disc, why we're coming from a ventral approach versus a posterior approach. And just for them to look at this, a picture speaks 1,000 words, and a video speaks far more than that. So it's just so great to have this technology and to see the responses of people when they get so much more out of the OR experience when they see this beforehand. And then you can have the medical student resident practice before the surgery. You can practice before the surgery. Obviously, that's a T-lift cage, but that was the only available model that we were able to use on this model. But you can practice the plate. using a small plate, drilling down the osteophytes, taking out the herniated disc. And it's just, it's amazing to show the patients and to all the people who are involved in the OR. And that's ultimately where we took it next. We sampled everybody. Actually, this one was a sampling that we do with the patients. And 88% of our patients strongly agree that experiencing the VR helped them improve their comfort level with the proposed treatment plan, which is my whole argument, that this just helps patients feel comfortable and understand better. And there's enthusiasm instead of fear in the office on the side of the patient. They understand. And then we're showing this value across the board with medical students, interns, residents, fellows, advanced practice providers, and attendings. This was just this is a paper that's going to come out. We basically used the VR model in the perioperative setting. We had just a small sampling of all the people who were surrounding, the anesthesiologist, the circulating nurse, the surgical technologist, the interns, the medical students, the residents, and really everybody found benefit. In this specific model, the attendings found the least benefit. Anecdotally, I think since then the attendings have taken an increased interest. I think that was one grumpy guy who set all the numbers off. But I think that there's tremendous value in everybody. I mean, just look at the anesthesiologist. Who would have thought that the anesthesiologist would be so enthused by this technology? It's really, people like to know what's going on and understand it, and it probably helps them prepare for the case and even maybe understand duration and risks better than they would without it. And this is what we're doing now. Almost every case now, we're practicing with the VR model beforehand. That's a medical student wearing the VR goggles, practicing putting a lateral mass screw in. And you can see, even just how we can tell them, there's no audio here, but we were saying, aim a little more laterally, start a little lower. And you just see, her adjusting to the appropriate trajectory. And then I would have killed to have this technology as a medical student to be able to practice drilling a cervical laminectomy trough beforehand. I think it's invaluable. And, of course, every step of the way, being able to practice beforehand. And even like you see the detail of the patients and their bifid spinous processes, just to look at it before, and you have such a good preoperative understanding of that patient's anatomy beforehand. And to get to the most exciting part of the talk, it's how can we help surgeons? I think on the left, it's the magic leap. On the right is surgical theater. But there's so many different technologies coming out and so many different subtleties to each technology. Some are more advanced in some ways, but further back in other ways. And I think ultimately we're all going to propel this forward and perfect the virtual and augmented reality to the most applicable way. But I will tell you that probably some of my co-panelists would do this case with ease, but I found this patient to be as complex as it gets. This was 11-year-old with a severe deformity. This is her axial cut, and you see her looking at some sagittal screw orientations. This is a coronal cut, and you're seeing coronal over here and an axial over there. These are the cases where I think having a model beforehand, I know some people are printing out a physical model, and that's very helpful also, but also expensive and time consuming. At least the one I use when I do that, it takes 1.5 to 2 weeks to get the actual model. This takes you 10 minutes and you're up and running with a 3D model of their spine, and you can practice as you need. You can mark the pedicle entry points in advance. And I think, at least in my hands, it's invaluable. So we did some projects with virtual reality, and we wanted to start with a lateral approach because, as everybody knows, the lateral approach is a great approach. Amazing for 3-4, 2-3, some for L4-5, and some experts like Juan Uribe at any level, basically. But I think that the anterior leg pain, the anterior leg numbness is definitely the most often cited critique of that approach. And if we can map out the lumbosacral plexus and how our approach is going to be impeded or not by the lumbosacral plexus, and understand where those nerves are, we can really do a tailored designed approach based on that patient's individual lumbosacral plexus with no extra imaging. So you don't need to, initially we did this, we got a MRI neurography to look at the lumbosacral plexus, but then we did it with a standard MRI, and you're able to see the nerves well enough to paint them. And I'm going to show a video of the one that we did with no special imaging other than the CAT scan and the MRI that we had. But ultimately, this may even be determined this may help us determine, is this patient a candidate for a lateral approach? And maybe if they are, can we tailor make an approach to minimize their risk of a deficit based on their plexus? This is just a patient who this had a nerve running right across their disc space, and you could see why you can get in trouble on these cases. And this is the model of where the lumbosacral plexus is most at risk. I don't personally do laterals at L4-5. A lot of people do and do it well, but at L4-5, it starts to get a little dangerous. In this patient, we did this mapping of their lumbosacral plexus, very posterior plexus, great candidate for L4-5, and L3-4 was free in the breeze. So I think that it's really nice to have, the more information we have about the patient and their anatomy in advance, the better. And then this is an augmented reality model of a deformity, and this is after we corrected it, but you can see how we can play with the model and we can simulate a deformity. We can simulate how we correct it. We can really play with it. We could even do like, we can do pontiostiotomies. We're not great yet at correlating what pontiostiotomies or VCRs or PSOs do to the model, but we can really play with the model and manipulate it in a way. In this patient, of course, we could simulate normal pedicle screws. That's kind of the first step. But to be able to take a patient with a severe, let's say, rotatory scoliosis that you're taking for correction, I find those rotated scoli cases to be the most complex and the hardest to get into a small, 3 millimeter pedicle, in, out, in, et cetera. But if you can really understand that pedicle and pull it out in space and rotate it and see its orientation, I find this tremendously helpful personally.
Jeremy, I'm sorry to interrupt. I just had a question. Can you? This is all. I love these pictures. Would you mind just, I guess, for the audience who is not familiar with this technology, could you just speak a little bit about the workflow that's involved to get that final product? Like, what do you have to do specifically? Like, do you have the X-rays, MRI? Like, what do you have to do to get that product right there?
Great question. So, I think that right off the bat, the CAT scan is the most important. You don't need a thin cut CAT scan, but a standard CAT scan will do, and that will create this model for you. I think that part is the easy part. If you get a CAT scan, you can build this model, and it's very fast, very quick, and very easy. It's almost like when you see in DICOM and PACS, you see that sometimes you get a CAT scan, they do that nice 3D reconstruction for you if you ask for it, at least at Sinai. So CAT scan reconstruction of this image is easy. What I find to be a big challenge is that we are not great yet at incorporating MRIs into these models and showing the neural foramen and the nerve going out and where the nerve is. If you have a herniated disc, it's not beautifully, we don't have beautiful sharp images yet of soft pathology like herniated disc, ligamentum flavum hypertrophy. So I think that we're so quick to get CAT scans now in a good way. I get them on almost every operative patient, certainly fusions. But I think that thin cut MRIs, like they are in cranial neurosurgery, I think thin cut MRIs are gonna become a little more common so that we can get better understanding of soft tissue pathology, spine tumors, herniated discs, stenosis, and incorporate them into this model better. But ultimately, a lot of the companies are doing this, but this specific one, keep in mind, I'm looking at the room. This is not a virtual reality, this is augmented reality. And I have this model superimposed on my view. The way I view this is I put on the goggles, I superimpose it onto the patient. And then if you have a tough pedicle screw, put on the goggle, you can use it for every screw. You could take it off, you could put it on for a tough screw, pull that blue vertebrae out, rotate it in space, get a better understanding of your entry point, your trajectory, how big the pedicle is, and then put in the pedicle screw.
How long does it take to register? Could you talk a little bit about that? Like, how do you register the patient's anatomy to that virtual reality image that you create?
So right now, it's a spinous process clamp. And I think the same way with navigation, you have the iliac option, you have putting it in between two screws and a rod, and that option. Those are all coming. Eventually, there are thoughts that we're going to be able to do a surface-based registration and not have to, do a separate stab incision or spinous process clamp. I think that's coming. but ultimately right now it's a spinous process clamp.
And this is based off of the preoperative CT. You don't have to get additional imaging in the OR. You don't have to get like O-arm spin or fluoro.
With right now, you do need to get an intraoperative spin. I think that that's another thing that's like, you fast forward 6 months, I don't think that's going to be the case anymore. I think it's just these things like roll out stepwise. So I think right now it's a spinous process clamp. Soon it's going to be 4 different options. Right now it's you need an intraop CT, but soon it's going to be based on the preoperative thin cut CT.
Very cool.
And most of these are smart enough that they pair with everything: Aero, O-arm, Zeem. Forgot the name of the new one. Yeah, great question. This is in the office. This is we did this augmented reality practice of some cervical pathology, and you could see how you could rotate the image. You have this beautiful picture. You have the arteries painted. You could bring in the esophagus, subtract the esophagus, bring in the cord, move out the cord, bring in the disc, remove the disc. And it's just really beneficial. Patients love this. It's like, I don't view it as, in any way as gimmicky, like, but patients just, they love this tech, particularly young patients, but really across the board. They leave your office and they just, like, they can't stop talking about it. We've gotten so many, we've got so much feedback from patients about how much they love this technology. This
Jerry,
is
I'm sorry, one more question.
Yeah.
Go back to that previous slide. How does the technology segment the vasculature, like the arteries there? Do you have to get like a CTA, or do you have to get like an any sort of vascular imaging, or it just kind of knows?
So good question. This patient had a CTA, which I think is why the vessels look as beautiful as they do. But we've done some with just CAT scans alone, and we can get them looking like this also. I think the CAT scan, it takes a little bit more time though, because you have to trace the vessel. But John, as a fellow Mount Sinai alumnus, you witnessed how in the beginning of using this technology in cranial neurosurgery, we would literally take every cut on an 80 slice thing and paint every picture, paint the pituitary tumor, paint the carotids, paint, everything, and then the optic nerves, but we did it 20, 30 times, and then they found a way to just automatically segment these things, and it became so easy, and it was so streamlined, and now it's like a 1 minute thing. I think the same thing is going to happen to spine very, very quickly, but in the beginning there are going to be these frustrating, time-consuming processes.
Yeah, yes, I remember those days very well. I still have nightmares about them.
This is a case we did last week. It's a C1 tumor, coming off the C2 nerve root. There was intimate involvement with the vertebral artery at the superior most aspect. This is an intraoperative picture that we had of the tumor here, the remnant of the C1 lamina. The vertebral artery was right in this vicinity. We put a Doppler on it and we saw it, but ultimately we had this, I don't have it here. We had this beautiful model of this tumor beforehand, and it made the case really, it was quite straightforward and really minimally painful. And this patient went home post-op day 1. And would we have done it the same way without it? Yes. But we have increased confidence going into the OR because we knew exactly what that relationship or the vert was? Yes. And I think you can definitely do it without it, but it just made us comfortable and it made the case easier. This was a C4-5 intramedullary ependymoma, and that cystic portion there. And just anytime you're cutting into the spinal cord, you want to have an understanding of where all relevant structures are and how it looks and how thin is that anterior rim of cord, which you can see on an MRI, but it's just nice to know in advance before the case. So I think, especially when you elevate the complexity of the case, having these models beforehand and studying them is extremely beneficial, at least in my mind. So I'll conclude here and leave time for questions. There's many applications of VR and AR in spine surgery that are constantly and rapidly evolving. Patient counseling, as we discussed, education of trainees, enhancing of procedures, and many more to come. these applications are undoubtedly going to expand and improve. And I think we need research. I need to prove to everybody, and we all need to prove to everybody why this is valuable, why it's going to improve outcomes, why it's going to improve patient satisfaction. And we're going to need to innovate and collaborate to take it to the next step. But I think we're well on our way. And like I said in my retweet of the post today, I think in 2022, everything I just said is going to be outdated. And I look forward to that. So thank you for your attention, and I'm happy to answer any questions. Oh, I ended a little early. Sorry about that.
Jerry, that was pretty cool. Could you go back to the picture? It's a little bit earlier where you were showing that the medical student. Yeah. Could you talk a little bit about that's surgical theater, right?
Yeah.
Could you talk a little bit about that and how that works? Because I think that's not a very familiar technology for a lot of our audience in terms of I don't really see that used too much in spine surgery, you know? So that might be something a little bit new.
Absolutely. So in this case, we merged an MRI with a CAT scan. We built this model. It took us about 20 minutes. I was very lucky because when I came to Sinai, they already had a surgical theater unit, so I didn't have to, push the hospital to get one. And it was very easy to transition from cranial to spine. They have amazing people who are there all the time, who are happy to collaborate, and they're as excited about this as we are. And then so step one was build a model. Is it accurate? Does it make sense? Does it correlate with what we see in the OR? And then step two is build this model, make it interactive. You have this virtual reality headset. You have someone walking you through it. You have these two controls. You can get a screw, you can get a drill, you could get a tap, you can get a hook. I mean, there's endless options. They have a toolbox, and you can sit there and you can practice doing whatever you want to do. I think sometimes you teach them the lateral mass screw and the laminectomy, and they're like, can I drill away the joint and see where I could get in trouble with the vertebral artery, or where I can feel how I can feel the pedicle and where the pedicle is. I mean, that's the beauty of this, is you can really explore anatomical relationships that are hard to appreciate when you don't have this. So we did drilling, tapping, putting in screws, drilling laminectomy troughs, really walking through the entire surgery from start to finish.
What kind of case have you done so far with the actual augmented reality headset? Or just putting in screws?
Yeah, we did it in models, of course, and then about 10 cadavers. No patients yet, and a lot of the limitations have come from COVID. So augmented reality, we're behind schedule. Virtual reality, we're chugging along. It's been a big frustration, as everybody here knows. I mean, COVID, of course, hurts COVID patients. They also hurt patients from not getting their physical therapy post-op and the little things that are not necessarily directly COVID driven. And much less important than all of those things is like even just share. You can't share headsets with patients anymore. You can't have patients come into your office. You have to see them in the exam rooms. All these little things that add up to make COVID impede rapid advancement of technology usage. So that's been a frustration in moving things along.
In terms of the workflow, have you found it to be easier, or do you think it would be easier to get an OR running with augmented reality versus a robot?
I think even now, the answer is yes. And I think going forward, it's going to be even more yes. I mean, I use the Globus in fellowship on around 40, 50 cases. I use the Mazor a few times. And to me, the most painful part was the registration process. I think that on a deformity case, T10 to pelvis, just taking those numerous APs and numerous laterals with all hands on deck, it still took a fair amount of time. And I found that to be very time consuming, less so on like an L45 MIS TLIF. Then it's kind of, you can get your flow going pretty quick. But, spinous process clamp is, as minutes. and you're up and running.
Hey, Jeremy, great talk. This is Mike Algano from upstate in Syracuse, New York. I guess one of the questions I have for you is, does your virtual overlay of the patient, does that ever obscure your view of a real-time pathology? Like, let's say that you have a vertebral artery injury, you get a CSF leak. Are you still able to visualize all of that with your virtual overlay on the patient?
So one thing is you could turn it on and off. And we're not at the stage yet, but that's coming too. You know, when you do heads up display, you're operating on a tumor and then you remove 40% of the tumor. Now you can kind of with certain, like for example, with Brain Lab, you can do the intraoperative update. So you paint what you've removed, you do an intraoperative update, and then you're back up seeing what you're seeing live. Similarly, if things shift during surgery because of, let's say you debulked a tumor and then things are collapsing in on itself, you can update it to, let's say like you have your vertebral artery and it's shifted 3 millimeters to the right. You can do an intraoperative update with a lot of technologies to drag it into place, and then you're back up and running with a more accurate model. So that's coming, and I think that's extremely relevant. And I think, you know, aside from CSF leaks, because of course, Mike, I don't get CSF leaks, but 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 on a practical level, I think you know, accounting for shift, accounting for pulsations and all that, I think that has to be part of this and has to be incorporated, and I think it will.
Hey, Jeremy, this is Matthew Goodwin from WashU. Great talk. Thanks for sharing this. What do you perceive to be the biggest hurdle in people in surgeons using this? You know, I'm a freehand person. I don't use nav, but I look at CT scans and I look at imaging up on the screen during the case. And I've played around with this, one thing I think is really nice, like you said, is you have everything kind of there. And, you know, with the added bonus of seeing everything, it's really impressive. You know, is the biggest challenge going to be this is competing with robotic stuff and it's a business thing? Is the biggest challenge going to be surgeons not wanting to wear a big headpiece, or what do you think the biggest challenge is going to be moving forward?
I think one nice thing about the headset is you could take it on and off with relative ease. And I think that's one of the nice things about the headset, but absolutely, I think we have to make the technology better so that it's more efficient, more user-friendly, and more easy, so that a freehand guy like yourself, it won't slow you down. It won't like add obstacles, because ultimately we all want to do it and just, you know, keep efficiency in the OR. I think that right now, in January 2021, it may slow you down a little bit, but I think that's a short-term thing. But I think that the biggest challenge is catching up to the speed of the surgeons, which I think is true of a lot of the new technologies. And I think all of us like to be efficient in the OR, and we don't want to be slowed down by anything. And I think, but I think that AR is not going to be much of a slowdown. It's not going to be much of a slowdown of flow. I think once this is adopted more mainstream, I think we're all going to drive it forward to make it more efficient. And I don't think it's going to really slow down people. So I think the biggest impediment is that it's not as fast as it needs to be. But I think that's going to be shortly, very, very quickly addressed.
And in that same vein, do you think this is something that's going to be combined with a robotic platform? I mean, one of the things you said that I really like is you you're still holding the instrument, you still have the feedback, you know. But I think a lot of people, and maybe I would say the same, would say, you know, well, the robotics is kind of the future. And so I guess, do you think that's true, and that these will combine, or how do you see that?
I think there's already talk of Globus introducing an AR component to their technology. I haven't seen it myself. I've heard that in the rumor mill. I think for sure these technologies are gonna drift toward each other and ultimately make each other better. I think there's a lot of, I think down the line, I think doing things like laminectomies with a robot, I think that's going to really incorporate AR nicely, because you're going to see, you know, what you need to see in augmented reality and be able to use the robot to do it with really fine control. And I definitely see these technologies being cohesive down the line.
Hello, Jeremy. This is Alexander from Switzerland, by Megani. It's really an impressive talk. I have a question about risks of AR. What are the risks? Because I got the feeling perhaps you are distracted from complications because you focus on the technical part, and maybe the patients are amazed because they know, wow, this is the technical part, I understand it better. But what about complications, wound infections, revision surgeries? Maybe they are distracted from these aspects. Do you think there may be a risk that that several important topics are perhaps not mentioned enough?
If I understand your question correctly, it's like we're focusing on the technical aspects using augmented reality, but we're not talking about the things that are not in the model, such as wound infection. Is that am I understanding correctly?
Not only wound infection, but maybe you're too focused on the technical part. Surgery will be the same, complications will be the same. But when the patient is focused on beautiful images, like this is so it's gonna be, this is our plan. I focus on if I tell my patients about surgery, I focus on complications.
Yeah, that's a great question. I think that for sure, I mean, I'm still having the exact same discussion with the patients as I had before, as far as from A to Z. I mean, you know, the Riot Act. I think that just with regard to technical complications, I think it's really helpful for them to see the model. I think that it certainly doesn't replace the conversation about all the other things that can go wrong, from anesthesia complications to medical complications to wound issues. And I think, I mean, the preoperative counseling session, I don't think you can under-explain, and I don't think you can overdo your risk discussion with the patient. I think from A to Z, I think everything has to be addressed. But I don't think the rest of the conversation will suffer because of the increased virtual experience for the patient.
Thank you. Did some med students join these surgeries? Were they impressed the transfer from the lab, from the computer to the OR? Did they have the opportunity to join these surgeries as well?
Absolutely, and I think they gain so much more from it when they practice beforehand, like that. Because I remember when I was a med student, when I was in the OR, they'd say, you know, do you see this? And I nod my head as if I understood, but I really didn't understand much. I think had I seen models like this, I just think I would have gotten so much more. And even in junior residency, I mean, you know, appreciating the subtleties of the surgery. I mean, I think to be able to practice and rehearse beforehand, if you have the patience to do it and you have the interest to do it, I think you will get so much more out of the OR than you would otherwise.
All right. Are there any more questions from our faculty? If not, I guess we can end a little bit early. It's about 10 minutes early, but that's okay. Well,
I did that on purpose. It's Thursday night. I want people to start getting out, enjoying their Thursday nights.
all right. Ali, do you want to introduce next week's presenter?
Yeah, absolutely. Thank you. Thanks, Jeremy. That was absolutely terrific. And you know, the only thing I'll add real quick as a follow-up from the previous comments is, you know, last week we had Dr. Martin Pham, who gave a terrific talk on robotics and how, you know, they're like the next best thing. And you've now given a nice presentation on AR. But the one common theme is that they are both obviously exciting technologies, but I like the fact that you were honest and transparent about the fact that today in 2021, it can slow you down a little bit. So, and Martin Pham, you know, listen, the reason we have you guys here is because you guys are excellent, you're honest, you're educators. And he said the same thing. He said in his hands, the robot, which he loves, he's passionate about, slows him down a little bit. And I think what's important, the message I got from this, and, we can't really evaluate this technology based on speed, based on, oh, is it going to, today in 2021, is it going to make my TLIF go faster or not? Is it going to make my T10 to pelvis faster or not? We all think about that, and it's important, but that's not how we're evaluating the current technology. That's not how we're assessing whether this is going to be good for our patients 5 years, 10 years from now. Somebody's got to take the hit, and I really commend you and Martin and others for taking the hit, if you will, because yes, it's slowing you down, but it's going to be so much better for all of us and for patients in the future. So I, for one, will stop evaluating that based on time, because that's not the metric that we should be using now. So I just want to say that. However, getting back to Dr. Rasouli's point, we thank everybody for joining us today. Next week, so next Thursday, we have a very special guest with a very special topic, Dr. Kara Sedney. Kara is a neurosurgeon from West Virginia University. She's a great colleague, spinal neurosurgeon there. And she's going to talk about a little bit different topic here. We've been focusing on technical aspects of spine surgery. She's going to talk to us about the stigma associated with certain spinal diagnoses. I'm really excited to hear what she has to say. And, I talked to her a little bit about this, and she wants to talk about how certain spinal diagnoses are stigmatized and how that affects patient care and postoperative care. So a very different topic, which is excellent. This is exactly what this platform is made for, to talk about both technical and non-technical aspects. So next Thursday, Dr. Kara Sedney, she'll be joining us from West Virginia University of Neurosurgery on stigmatization in spinal diagnoses. So join us next week. Jonathan, back to you to wrap it up.
All right, everybody. So I'll give my 2 cents on this. I think this is fantastic technology that, it's a little bit slower than we expected to be adopted. But, we have outstanding surgeons like Jeremy who are, kind of the forerunners of this technology and really bringing it to the forefront. And this is stuff that if we don't adopt it, it's just never really going to go anywhere. The more people that, kind of step forward and start using this, add a couple of minutes to our OR time, this technology is only going to get better, but there has to be a demand for it. If nobody uses it, it's just going to be a paperweight and no one's going to do anything with it, I think where this technology really shines is with minimally invasive surgery. In open surgery, do you really need those? You see all the landmarks. You don't really need to have like a headset. But with minimally invasive, you're very reliant on external imaging, on X-rays, on your fluoro, on your navigation. And if you have an extra layer of confidence, especially with this really high-tech, state-of-the-art technology, I think it's only going to make the surgeries go much better. It increases your confidence, and will promote surgeon longevity and just the ergonomics of those cases in general. So anyway, thank you, Jeremy. That was an awesome talk, and I thank everybody for joining us tonight. And I hope to see you all next week for Dr. Sedney. And hope you all have a good night. Thank you.
Thanks a lot. Good night, everybody.
Thanks, guys.
Thank you.